Good afternoon and welcome back. Hope everybody was able to grab lunch. We are going to continue with our afternoon. Just as a reminder, the slides and the recordings will go up later this week on the course website. And of course, each of our talks are going rather quick. We have a lot of content to cover, of course, for the boards. Wonderful. So our next speaker, we are very lucky to have Dr. Kraus, who will be speaking to us about different neurology topics for the medicine boards. And it looks like Dr. Krause right now, the presenter view is what is being shared. Perfect. All right, I will turn it over to Dr. Krause, who has a long history of being a wonderful, treasured educator at the University of Washington. Dr. Krause, whenever you are ready. Oh, actually, it looks like the slides came. There we go. Okay, they're back up. I will turn it over to you.
Great, thank you. I am happy to be here. Yes, I'm going to try and cover a fair swath of neurology in a short amount of time, and I'm going to do it with some cases, so hopefully you'll all add to the poll. I'm going to start with a case here. It's a 48-year-old male, presents with gradual progressive weakness of his proximal legs and arms without sensory loss. The exam confirms the weakness, reflexes are reduced, and you find no fasciculations. On exam, the best anatomical localization is. So I divide the nervous system up into 7 different categories. I'll just give you 5 choices here. Do you think that localization is best in this case to the brain, muscle, motor neuron, spinal cord, or peripheral nerve?
Do you see the results, Dr. Krause?
I do see the results. I think the recommendation was wait for 70% participation, but I think it has stalled at 45%. I'll just keep going here. All right. So the best localization for this, so it is a motor-only process, but it is just proximal muscles, which is often a clue to a muscle problem. And fasciculations are often extremely common in motor neuron diseases. So the best answer is actually a muscle problem, a myopathy for a case like this. Let's try a second one, then we'll talk more about localization. A 52-year-old male presents with subacute sensory loss in the feet that extended to his chest. Arm sensation is fine. Weakness is present in both legs, and there's urinary urgency. So both motor and sensory and urinary trouble in the trunk and legs. The exam confirms leg weakness without atrophy or fasciculations, and there's a sensory level at T6. Best localization here, brain, muscle, motor neuron, spinal cord, or peripheral nerve. Okay, well, the number one answer here was D, spinal cord, which is correct. That's a very good history, bilateral motor and sensory with bowel and bladder trouble. It can't be motor neuron disease because there are sensory symptoms, and motor neuron diseases are sensory, motor-only diseases. And peripheral nerve would not explain things going on in the trunk. So next thing we're going to do is just talk about levels. So I want to give you some pearls that will help you both for taking your test, but also in general about thinking about a neurological problem. So I divide the nervous system up into the 7 different levels over here on the left that you can see. And I'm going to go through every one individually. But over here on the right in the picture, we have the brain up top. So this is the frontal parietal lobes, temporal lobes down here, corpus callosum. This is the thalamus that I'm circling here, the brain stem, which is midbrain, pons, and medulla, the spinal cord down here. So if we start with the red fibers here, which are the upper motor neurons, so the cell bodies are the circles, and the processes run through the corona radiata, down through the internal capsule, into the brain stem, down in the medulla. They cross in what's called the pyramid, and so this is the pyramidal system. And at every level of the brain stem, but also of the spinal cord, it's going to attach to an anterior horn cell, which then runs out to the muscle through the neuromuscular junction. So lower motor neuron, upper motor neuron. And then sensory fibers run the opposite way. It can be from the skin, but I have here a Golgi tendon apparatus sensory fiber, which runs back to the spinal cord. The dorsal ganglion is the cell body for these nerves. And for a reflex, it's going to have a quick attachment to the lower motor neuron back out to the muscle. But for a lot of sensory information, it goes then back towards the thalamus, and from the thalamus distributes up here to the sensory homunculus in the parietal lobe. So this is a simplified version, but let's take this information and talk about each level. So the brain. The brain is a very big structure, so the things that affect the brain are typically going to cause unilateral symptoms, at least first. It can be bilateral, but often unilateral. There are both motor and sensory tracts up here, as you can see. Something might involve both or just one or the other. But there are some things that are more specific to the brain, such that if you heard these things, you'd say, aha, at least the brain has to be involved in this case. And that would be things like language, consciousness, memory, behavior, vision, seizures, and most movement disorders come from the brain. The next level down is the brainstem. The brainstem is still a pretty big structure, so the things that affect the brainstem are often unilateral, but may have the crossed face-body syndrome that people have a clue to hear about. There are both motor and sensory tracts again. There is some consciousness here in the reticular activating system, but you're going to be looking for cerebellar findings, which sit behind the brainstem. Many movement disorders come from the brainstem. And think about our cranial nerves involved, like double vision, vertigo, face, swallow, tongue symptoms. Now, cranial nerves doesn't mean that it has to be the brain stem involved. You could have a peripheral cranial nerve involved, but when there are cranial nerves, it could make you think about a brainstem localization. As we move down in the central nervous system, we get to the spinal cord. Okay, so in spinal cord disease, things are often bilateral because now the spinal cord is tiny relative to the big brain stem in the brain. The spinal cord is about the size of a dime. So things that affect it are often bilateral, usually have both motor and sensory dysfunction, along with bowel, bladder, erectile dysfunction, just like the second case that I gave you before we started going through these systems. And by definition, I guess, if the spinal cord is what's involved and nothing else, then the head should be okay in this situation. All right, those top 3 things, the brain, the brainstem, and the spinal cord, are the central nervous system. The bottom 3 are going to be the peripheral system. And the middle one, the 7th one here, or the 4th one here in the middle, I refer to as motor neuron disease. Now, this is a hard concept. Most people mistake saying a upper motor neuron disease is equivalent to something in the central nervous system, and a lower motor neuron disease is equivalent to something in the peripheral system. But that's not true. There are lots of other things going on in the central nervous system and peripheral nervous system than motor neurons. There are sensory neurons and language neurons and conscious neurons, so on and so forth. So when we say a motor neuron disease, we mean that it's the cell body of the motor neuron, the Bet cell up here and the anterior horn cell down here, that are affected. And so generally symptoms are bilateral but asymmetric, motor only. They can go out to muscles that are both proximal and distal, like the swallow or the shoulder, but also the hands and the feet. It's typically insidious in onset. And a very frequent physical exam hallmark of motor neuron diseases is the fasciculation. That is a twitch underneath your skin of the muscle. Now, this twitch is not big enough to actually move the limb. It's just a small amount of muscle fibers. And I suspect that 95+% of all of you have had fasciculations in your life. You've had this annoying eyelid twitch before, or big muscle groups after working out might twitch for a little bit. So very common, but when they are present with a disease that involves weakness and maybe reflex changes and it's progressive, it might mean a very bad disease. And the most common bad disease for an adult in this category is ALS, or Lou Gehrig's disease. Now getting into the peripheral nervous system, the first level is peripheral nerve. So this is a big area. This is everything from the root of the spinal column out to the muscle or the skin back to the spinal cord. That's all peripheral nerve. And peripheral nerve diseases can be symmetric, they can be focal, they can be multifocal. One of the hallmarks, though, is that the sensory fibers of our peripheral nerve are just easily more damaged than the motor fibers. And so you often have sensory symptoms before you get motor symptoms. Remember that our cranial nerves all come out of our brainstem, but have a peripheral nerve component as they're getting to where they're going, and so they can be involved. And the most common presentation is a distal sensory presentation, what we call the stocking glove distribution of symptoms. So the farthest away from center or length dependent. Now, sometimes nerve diseases, though, can be both proximal and distal. So if you affect the nerve in the cauda equina, that's peripheral nerve, then you might have symptoms that are both proximal and distal in the legs. And if you have a demyelinating condition rather than an axonal condition of the nerve, demyelinating conditions are often both proximal and distal as well. All right, getting down to the second to the last one, we're getting out farther peripherally. This is the neuromuscular junction. So by definition, this is a neuromuscular junction disease. So it's a motor-only process. It's not a neurosensory junction disease. It's usually asymmetric and bilateral. And for the most common disease in this category, which is myasthenia gravis, the eyes will be involved. In fact, 90+% of the time in the first, if not the first symptom, in the first few months, you'll have eye symptoms in myasthenia gravis. And the other characteristic of myasthenia gravis is what we call fatigable weakness. So it's not just fatigue. Lots of people have fatigue. But if you actually objectively get weaker when you're doing things, that would be a good sign of myasthenia gravis. There's another disease that's less common in this category that you might see that presents more with progressive weakness rather than fatigable weakness, and that's the Lambert-Eaton myasthenic syndrome. Now, I know some people think of this disease as getting better with exercise. It's not entirely true in the clinical setting. Patients don't come in and say, "Hey, I felt better because I just went and ran 5 miles." The increased function with exercise is more of an electrical EMG evidence that helps make the diagnosis. But Lambert-Eaton myasthenic syndrome. Botulism also falls in this category of neuromuscular junction disease. And then the final category, out the most peripheral, is muscle disease. It's usually symmetric, it's motor only, and it's usually proximal muscles. Now, there's a lot of variation to this, but for patients who present with weakness in their hips and shoulders, muscle disease would be something to have high on your differential list. Okay, with that in mind, let's try another ARS question and use these new skills to help with this. This is going to be a two-part question, though, so a little bit more difficult. So there's a 56-year-old woman with gradual weakness of her right arm, such that she can no longer open jars. She stops playing tennis 3 months ago. Her gait feels stiff, another motor problem. Her friends wonder why her speech is slurred. She denies sensory, cognitive, or bowel or bladder difficulties. Her exam is remarkable for diffuse weakness with hyperreflexia that's greatest in the right arm. And remember, she was the weakest in the right arm. And there are diffuse fasciculations, a buzzword to remember. What test is likely to confirm your diagnostic suspicion? So you need to think about localization first, think about a disease, and then what test. And your options are a brain MRI, spinal fluid for increased protein, cervical MRI, electrodiagnostic testing, or something called a tibial evoked potential, which looks at your sensory pathways through your central nervous system. Okay, so very good. The best answer was D, electrodiagnostic test, which is correct, because this is a progressive asymmetric motor-only problem with fasciculations. It's likely to be ALS, and the best test to help make that diagnosis is an electrodiagnostic testing. Cervical MRI scan is sometimes done when you're working up ALS, but in this case, because the patient already has dysarthria, something above the neck, the cervical MRI will not be helpful. And the brain MRI, just something pure central nervous system, is not going to be helpful because fasciculations are a peripheral nervous system problem. So the brain couldn't be the cause of all of these things. So, what is ALS? It's a degeneration of motor neurons. Okay, so the pathology is here in the cell body, not just in the nerves coursing through the nervous system, but in the cell body for the upper motor neuron and the cell body for the anterior horn cell. And because it's dying there, that degenerates the rest of this whole nerve. Etiology is not known other than some genetic causes, no sensory vision or bowel or bladder trouble. But interestingly, in the last 10 years, we've recognized that 20% have dementia. It's amazing we didn't know about that or think about that in the last thousands of years that we've known about this disease. Asymmetric weakness, it can start in what we call the bulbar region, which is the medulla, sort of swallow and tongue-ish areas. Survival is 2 to 5 years. And there are a couple of medications I won't go into called riluzole and edaravone that have been shown to modestly extend life, maybe by 3 months. So not great, but at least something to offer. And how do we make the diagnosis? Well, the first thing is a history that fits, a motor-only progressive disease, physical that fits, showing both upper and lower motor neuron problems like weakness and spasticity, but also fasciculations and atrophy. And then finally, a EMG, which you stick a needle into people and you look for evidence that the nerve is not getting to the muscle, so denervation. You look for evidence that other nerves that are healthy are attaching to the muscle that was already denervated, so that's reinnervation, and you can actually see fasciculations, and you'd like it to be in several parts of the body. And one of the best places to look is the thoracic spine. The reason is that pinching of a nerve, a radiculopathy, also gives you denervation and then reinnervation, but you rarely get pinched nerves in the thoracic spine. So if you see denervation in the arms, but also the limbs and the thoracic spine, that's a very good combination for ALS. All right, I'm going to move on to a new set of questions here and topic. 66-year-old female presents with acute onset of sensory loss in the right face, arm, and leg. So a hemisensory syndrome, no weakness, vision, or cognitive change. So your job is to think about, well, what disease does this sound like, and a reduction of which risk factor will have the greatest impact at preventing a second event. Is that hyperglycemia, hyperlipidemia, weight loss, hypertension, or smoking? All right. So there were four of the five answers were picked. The number one answer was smoking, which is not correct. Hypertension is the biggest risk factor. So we're talking about a stroke here. And more important is just the characteristics, which was hemisensory loss, but nothing else going on. And so generally, this is, one of the classic, what we call lacunar syndromes. These are small strokes that happen deep within the brain. The motor ones, which are most common, is either the internal capsule or the pons, but pure sensory strokes, as this case was, would be in the thalamus. And the pathophysiology of lacunar syndromes is what we call lipohyalunosis, so small blood vessels. And by far the most important risk factor is hypertension. I'm not saying diabetes and smoking aren't important, but of all the things that you can do to help prevent another stroke, hypertension is the one to treat. And so here is some information. These are the American Heart Association guidelines, last put out in 2021 to help with secondary prevention of stroke. Now, of course, we want to prevent the stroke initially, so treating blood pressure, as you all know, is important. But from a secondary prevention point of view, we have our class of recommendations. We have three class one recommendations here. The first is to treat their blood pressure, and you can pick any number of different blood pressure medications. And the bottom one down here says, well, why not pick medication that has multiple uses for whatever the patient has, so comorbidities. And then the middle one here is to say that our current blood pressure goal is to get them less than 130 over 80. So. The second one I want to mention is cholesterol control. We also want to do that. There are a couple of good class one recommendations for cholesterol. And it says if you've had an ischemic stroke, your goal is to reduce their LDL, especially if it's greater than 100. And rather than just, sort of lowering it with moderate or small doses of a statin. The high potency, high dose statin is recommended just from the start, such as 80 milligrams of atorvastatin, or I put down here at the bottom rosuvastatin, 20 to 40 milligrams. Those are the high intensity statins that we use. And our goal, officially by the AHA, I'm going to show you another slide in a second, is to get the LDL below 70 in everybody who's had a stroke. Some new data, it's not yet part of the full guideline, but that's come out in 2026. The guidelines may change, is that for very high-risk patients with multiple cardiovascular events, so strokes and heart disease and peripheral vascular disease, that try to get the LDL down to 55 or less, so very low. It used to be thought that if we got the cholesterol too low, that we'd have more chance of having hemorrhages, but the recent studies show no increased risk of hemorrhages in the brain with this. And so other options, if statins don't do the whole trick of getting this down, can be to add ezetimibe and a PCSK9 inhibitors. And I'll just say that this AHA recommendation says to consider second to be the ezetimibe. All right, but what are our options for antiplatelet therapy in somebody? So for most patients that have a stroke, we're going to be using antiplatelet therapy. Now, there are, of course, conditions like AFib that we use anticoagulation, but the options we have in general, and there are other ones like ticagrelor and such these days, but the main ones we use in stroke are aspirin, often 81, sometimes 325. It's inexpensive, often a first choice, even though clopidogrel probably has a little bit more evidence as first line, but because it's expensive, it's used less often as first line. And then there are some situations in which we use dual antiplatelet therapy. Now, you know you're used to doing that in cardiac stents and for other reasons, non-brain related. But I'll just give you a little bit more information about some guidelines back in 2018 for dual antiplatelet therapy. The idea is that if you have somebody who comes in with a minor stroke or just a TIA, but a high-risk TIA, and you can start the dual antiplatelet therapy within 24 hours, that will reduce the rate of another stroke in the next 90 days by about 2%. And we use it for 21 days. Now, a minor stroke means a minor stroke scale of 3 or less. So you have to do the scoring. And a high-risk TIA, there's a scoring for TIAs called the ABCD2 score. And if it's 4 or greater, they're at high risk of having another stroke. So if they meet these criteria, then we use dual antiplatelet therapy. If they don't, then we would just use single antiplatelet therapy. The reason is it's just that dual antiplatelet therapy just leads to more iatrogenic bleeding problems, either in the brain or the stomach or wherever it might be. All right. Sticking with stroke, but going in a different direction, a 63-year-old male presents with right hemiparesis and hemisensory loss and a non-fluent aphasia. So compared to our last story, which was just sort of loss of sensation, but not motor or language, or just loss of motor, but not sensory or language, now we have all of that going on, which means this is not going to be a lacunar syndrome, a very small stroke and deep in the brain. This is going to be a larger stroke in the brain. And the workup ascribes the cause to an emboli that came off of a left carotid artery stenosis. And the stenosis was only 50%. So sometimes stenosis is a low risk of emboli, and sometimes stenosis with a hemorrhage and a broken plaque can be a high risk for emboli. But what treatment do you recommend to prevent another stroke in a patient with 50% carotid artery disease? And I give you only 3 choices for this. Great. So the number one answer people gave is antiplatelet therapy, which is correct, over anticoagulation. And because it's only 50%, carotid endarterectomy would not be done in this situation. I'll just give you some evidence for this as well. The American Heart Association guidelines, again from 2021, looked at carotid disease. They looked at both stenting and endarterectomy and stenting, and there were 3 class 1 recommendations. So if the TIA or non-disabling stroke was on the ipsilateral side of the carotid stenosis, and 70 to 99%, they recommended carotid endarterectomy. If for some reason it would be too dangerous to do an endarterectomy, then a stent would be okay. And in addition, always prescribing lipid-lowering drugs, antiplatelet therapy, control of hypertension, diabetes, all of those things, stop smoking, and so on. Now, if the stenosis is not to this high-grade level, then we would just do all these other medical things to treat the patient's carotid. So let's see here.
Cross, just real quick. So I see the recommendation says non-disabling ischemic stroke. So in the event that there were more significant consequences from the stroke that was disabling, then you would go ahead with the procedure?
No, no, I'd have to go back and read the actual paper again to see why they put in non-disabling ischemic stroke in the past 6 months. I think the idea would be if you've already occluded and had a huge stroke on that side, and there wasn't much to lose if the carotid stenosed all the way, that maybe you wouldn't do it. There, of course, is the surgery itself, whether it's CEA or stent, has a risk of causing stroke. And so there are a bunch of other criteria in here about, do they have at least 5 years to live? Is their morbidity rate for the surgery less than 6%? What are their patients' other risk factors? So there's a lot that goes into this, but I don't think the disabling means do it sooner. So what I was going to say is just another big pearl. When thinking about anticoagulation for a stroke, this is simplified, but because artery to artery disease and artery thrombosis in general is going to be a platelet-mediated event, the goal is to treat with antiplatelet therapy when the artery is the cause of the stroke. If the vein is the cause of the stroke, either with a cerebral venous thrombosis or with a DVT with a right to left shunt through a PFO that goes to the brain, then the treatment is going to be anticoagulation over antiplatelet therapy because those are the things that prevent clots in the veins. And then the heart is a little bit of a mixed picture. There are sometimes for heart disease, like a pig valve, or a Chad's VAS score that's 0 with AFib, that you might use aspirin. But for the most part, with heart disease, you're often going to add anticoagulation as the Chad's VAS score gets higher, or they have a metal valve or whatever it may be to prevent a stroke. All right. Next, 63-year-old male presents with right hemiparesis, hemisensory loss, and non-fluent aphasia. So the same case, okay? So big stroke. Now we're going to think about a few other things with stroke. Time of onset was 3 hours ago, and the right workup reveals a left proximal MCA occlusion. What treatment do you recommend? Antiplatelet therapy, tenecteplase alone, or TPA cousin, a thrombectomy alone, or both TNK followed by thrombectomy, or just sub-Q heparin. Okay, the number one answer was D, which is correct. So if you're within a certain time frame, you can give people TNK, TPA, and so 3 hours meets that. But because there is an occlusion, you want to also do a thrombectomy. So this would be the proper approach here. Now, when someone asks, well, what if you do the TNK and it resolves the thrombus, and then there's no thrombectomy to do, and that's fine. You would figure that out when you went in with an angiogram. There'd be nothing to do, but the TNK should be given. In fact, this is sort of an interesting recommendation. We used to think that if you were already going to do a thrombectomy, you could probably skip the tenecteplase and just get them quicker to the angio suite. But a study just last year suggested that no, patients do better if they get the intravenous tenecteplase followed by the thrombectomy rather than just the thrombectomy alone. So that's our current model for treating people. And so just a little information about some other stroke trials and why we do what we do. So what's interesting about all these stroke trials is that they pick the same outcome for them, which is really quite nice, or at least most of them. And the outcome that they picked was how many strokes do you have to treat to put one more patient in the good outcome category where they would have had a poor outcome prior to that? And good outcome was no or minimal disability at 3 months, essentially people going back to work and living their normal life. And so the first studies that were done were sort of time-based with last known normal. And we used TPA back then. Now we use tenecteplase, at least here at our institution. And the first study was done and said you need to give the TPA within 3 hours. And it turned out the number needed to treat, again, to take one patient from a bad outcome to a good outcome was only 7 patients. This was quite amazing for us. But set 3 hours is a short period of time. And so they extended the window, which is now the correct window for TPA or TNK, which is 4.5 hours. And the number needed to treat was 14. So not as good. This just reflects that time is brain. The sooner you can give the clot buster, the better. Okay. We also have the problem with people coming in without a good last known normal, and that's a time-based, what we call wake-up stroke. And for that, we need a little bit more information. We can't just use time. We have to also use something called a perfusion mismatch CT scan or an MRI scan. And I'll just show you an example of that. Here's an MRI scan example. So on the top ones up here are 2 cases in which there's a stroke where we could give a TNK. So when the diffusion imaging is positive, but the flare sequence has not had time to become positive yet, we use this as a surrogate to say that it's under 4.5 hours because the flare signal change starts to come in at about 4.5 hours. Here's another case, positive DWI, so acute stroke, negative flare, so not showing up on this sequence yet. That means under 4.5 hours. On the other hand, this is a patient where you wouldn't give the TNK. They woke up with a stroke, but their stroke probably occurred earlier in the evening rather than right before they woke up. In this case, the DWI proves it's a stroke, but the flare is already positive. So past 4.5 hours, the DWI positive, the flare positive, past 4.5 hours. So this would be a way to pick up more people to get TNK when they wake up with a stroke. All right, the next thing is when do we do thrombectomies? This has changed a little bit. When there's a large vessel occlusion, we used to say that that include the internal capsule, the proximal MCA branch, and we used to say also moderate MC branches, M2. We no longer do that in most patients. It didn't show to be helpful, but internal capsule, proximal M1 or the basilar artery, and then it's also time-based. So you can do a thrombectomy without any other information. If you're less than 6 hours, the number needed to treat, again, to put one more patient into the good category was only 7 patients. Pretty remarkable. We also say now that if you have this large vessel occlusion, you can think about time, but if you also do a perfusion mismatch in the 6 to 24-hour range, the number needed to treat is now only 3 to put people into a good range. Neurology doesn't have a lot of interventions that we do that change people's lives so much as this. So pretty important to think about it. So what is this perfusion mismatch? It's a CT scan that looks at 2 things. One is, it's color-coded here, the area of the brain that's dead, that's in pink. It gives you a volume, 16 milliliters of volume is in pink, dead tissue. You cannot change that. That's already dead, no matter what you do. But it also asks the question, well, what about tissue that just has blood flow getting there that's delayed? So it's slow getting there, but it's still viable, meaning if you do the right things, you can change this green to just the background color. You won't change the pink. So there's the core, but the green can be helped. And so in that situation, between 6 to 24 hours, a thrombectomy is worthwhile. If this green was the same size as the pink, then it wouldn't be worthwhile to do the thrombectomy. And so that's how they look at it. There are some ratios that you need here. The radiologist will tell you all that. But this is something that's not used infrequently to try and help us figure out what to do. All right, then the last stroke topic before we go on to some other diseases is an 82-year-old woman with diabetes and atherosclerotic coronary vascular disease. On the day prior to admission, she had acute onset of left vision loss and a headache. The workup showed a right temporal occipital hemorrhage. So this is a CT scan. Things that are bright can either be calcium like the skull or blood, and she's already on aspirin. Now, the harder thing is to decide what is the most likely cause of this lobar hemorrhage. And here are some popular things we think of when people have a hemorrhage. In this location, what we call a lobar hemorrhage, which cause do you think is most likely? Amyloid angiopathy, hypertension, endocarditis with septic emboli, a vascular malformation, or an underlying brain tumor that has bled. All right, wonderful. Well, I'm very happy with the answers. Number A, amyloid angiopathy is the correct answer. But hypertension is by far and away the most common cause of bleeding in the brain. So certainly not wrong to think about that. But let's just talk briefly about this. Again, the most common cause of bleeding is hypertension, but usually the bleeding is deep within the brain. So this would be more in the basal ganglia area. And you can see that it's pushing from the right side over here to the left side of the brain. You can see the shift of the brain. That would be a typical location for a hypertensive bleed. Turns out, though, that when the problem is amyloid angiopathy, so amyloid deposition in the blood vessels, making them weak, you get these lobar hemorrhages. That's where it deposits. And important because they're always going to be at high risk for bleeding in amyloid angiopathy. So that affects how you treat people. Whereas with hypertension, you had this bleed, but you can control their hypertension and lessen their risk of further bleeding and use other antiplatelet therapies and other things pretty easily. Whereas with amyloid, you get a little worried about using any antithrombotic therapy. With this. And just to be clear, the amyloid we're talking about is the same amyloid that is in Alzheimer's disease. And so many patients who have amyloid angiopathy also have dementia at the same time. All right, next topic. A 24-year-old female presents with blurry vision and pain in the right eye for 3 days. Last year, she had numbness in the left leg for 2 weeks. So she's got two things happening over a span of a year. To make a presumptive diagnosis, so a two-part question: what is that diagnosis, and prescribe what to treat her for her acute symptoms. Do you give her beta-seron, IV steroids, ocular steroids, amantadine, or a drug called natalizumab? All right, people did great. So the question I asked is, what do you do for the acute symptoms? And for acute multiple sclerosis attacks, it is steroids. Now, I'm not saying you shouldn't start to think about drugs that are going to prevent more attacks. And so A and E are possible things to do. But at least in the acute setting, we're talking about IV steroids. And I'll give a slight variation on that in just a second. But so for MS, our level 1 evidence is to give methylprednisolone, big doses, 1,000 milligrams IV for 3 to 5 days. And that sort of helps stop the inflammation and the process going on so that people can heal faster. However, it doesn't change how well people are doing 6 months later, right? But having somebody walk or see 3 months earlier than they would otherwise, that sounds like a good thing to do. On the other, but there's some level 2 evidence that says, yes, you can use IV methylprednisolone, but it turns out that you could also just give a PO equivalent. So let's say you had a patient who wasn't near a hospital or was traveling somewhere. You can actually just give the PO equivalent of the IV methylprednisolone and get equal results. And it turns out that 1,000 milligrams of IV methylpred is 1,250 milligrams of PO prednisone. Now, you might say, well, nobody's going to tolerate that. But the truth is, in my experience, people tolerate it just fine for those 3 to 5 days. And there's also some evidence about whether you need to give IV methylprednisolone alone or whether you should give IV methylpred followed by a prednisone taper for, say, 10 days. And that's pretty variable about what people do, what MS specialists even do in this situation. So next case, 56-year-old male. Oops. Presents with trouble walking, small handwriting, and a resting tremor. Again, a two-part question. You make a presumptive diagnosis and suggest what? Cinemet trial, head MRI, propranolol for essential tremor, stroke workup, or an SSRI for anxiety. Okay, wonderful. So I think the correct answer is just to do a Cinemet trial. It's certainly not wrong to image people, but in a case of somebody with sort of a classic Parkinson's disease, you're not likely going to find anything with an MRI scan. And if they respond to Cinemet, that's how we make the diagnosis of idiopathic Parkinson's disease. Now, if they don't respond to Cinemet, you'd go back and rethink, well, what else could look like Parkinson's disease, some other form of Parkinsonism, and there are a lot of those things, and you might do some imaging after that. But I think very fair to just go straight to treatment. So Parkinson's disease, slowly progressive disease. The three cardinal features are resting tremor, bradykinesia, and rigidity. These features lead to gait trouble as well, and they often have dementia, depression, other autonomic symptoms are not uncommon as the disease progresses. And the best treatment we have by far is levodopa over here. That's generally combined with carbidopa to help prevent side effects in the form of Cinemet. And the levodopa converts to dopamine, and it's dopamine that's lacking in people with Parkinson's disease. Again, by far the most potent drug. We also use some dopamine agonists at time, like ropinirole and pramipexole and such. They work synergistically with levodopa. And then there are a couple other categories of diseases we'll not, or medications we'll not talk about today. Next case, 42-year-old woman with uncomfortable feeling in her legs 5 days per week in the evening, not in the morning. Walking will relieve the problem temporarily, but when she sits back down, it comes back. Her neurologic exam is normal. What test should you order? Again, a two-part test. You make a diagnosis and think about copper and ceruloplasmin, B12 deficiency, potassium deficiency, iron studies, or a TSH. Fantastic. Rarely do I ask a question and get 100% correct answer on things. Kudos. Very good. So this is a diagnosis of restless leg syndrome. Okay. So the key here is people feel restless. Now, they don't always feel restless. I shouldn't say that. They feel a sensory symptom. They may describe it as restless, but some people describe it as ants or tingling or aching or gnawing or burning or cramping or something. And movement helps. And so that's the other key feature. If you get up and walk, it should go away. You sit back down, it comes back. So those are the sort of key features of restless leg syndrome. And then the other one is that patients move because it feels better. While people are awake, they shouldn't have involuntary movements. Patients move voluntarily because it helps. Now, there is a associated disease, not the same disease, of periodic leg movements of sleep. And so when you're sleeping, you do have these involuntary foot movements, but people can have that without restless leg syndrome as well. So they're not exactly equal, but while awake, they are not involuntary movements. And we know that low iron is one of the secondary causes of restless leg syndrome. And so primary cause is thought to be a dopamine deficiency in the brain, but secondary causes include a lot of things up here, like uremia, iron deficiency, pregnancy, many medications, venous insufficiency. And if you find somebody with iron deficiency, well, I shouldn't say that. If you check their iron, if their ferritin is in the normal range, but on the lower side, they still might benefit from iron. And At least in up to date, they recommend getting people up to about 75 nanograms per milliliter, when I think 20 is the official normal range. But the drugs that help the most are gabapentinoids, so gabapentin and pregabalin, and they're often first line over the dopamine agonists, which work very well as well, but they can get into some trouble with um, overuse and refractory symptoms when using them. Next case, 26-year-old male with a diarrheal illness 2 weeks ago. They have distal paresthesias, started 2 days ago, followed by leg weakness yesterday, and today can't get out of bed. So it's a pretty rapid process of a sensory and motor issue. Denies cognitive or bowel or bladder difficulties. The exam is remarkable for a poor smile. So there's facial weakness as well, proximal distal weakness in the arms and legs, and areflexia. Eye function and pupils are normal. So again, a two-part, you make the diagnosis and you want to start treatment. And in this disease, no treatment is helpful. B, either IVIG or plasmapheresis. C, steroids or IVIG. D, steroids or botulism immune globulin. All right, great. People did very well. The number one answer was B, IVIG or plasmapheresis. And that's correct. To answer this, you had to decide, well, this is an acute, probably immune-mediated neuropathy, Guillain-Barré, in other words, and the treatment is IVIG or plasmapheresis. That's steroids don't help with Guillain-Barré syndrome, at least not Guillain-Barré that we typically think of. I will say that immune checkpoint inhibitors now can actually trigger Guillain-Barré, and steroids are actually the treatment of choice if it's an immune checkpoint inhibitor induced Guillain-Barré syndrome or other autoimmune syndrome. So interesting aside to that. But for most of the Guillain-Barré, it's IVIG or plasmapheresis. So what is Guillain-Barré? Well, that usually starts with tingling because it's a nerve disease. So tingling is usually first, followed by ascending weakness, which just means it starts in the arms and legs before it gets to the face. There are variants actually that start in the face, so it's not always perfect. It doesn't have to start in the toes and work up. It can start in the arms first or the legs first. But the face is often involved, usually symmetric, absent reflexes. They can have autonomic symptoms, and a common cause would be a diarrheal illness with Campylobacter. The studies we use to make the diagnosis, in addition to history and physical, are high CSF protein and a EMG or nerve conduction studies that show slow nerve conductions, leading to the diagnosis of the AIDP variant of Guillain-Barré, which is a acute inflammatory demyelinating variant of Guillain-Barré is the most common. Lots of variants of Guillain-Barré, which we won't go into, but maximum weakness is within 4 weeks, slow recovery. 85% of people do really well. 10% remain disabled, and 5% die, usually because of trouble with intubation and bed sores and ARDS and other things that happen in the ICU. And the treatment to try and avoid complications, but to start plasmapheresis or IVIG. Your experience is probably the same as mine, which is IVIG is just easier to get. To start, it's 5 days rather than 10 days for plasmapheresis, and so that's often the one that's used. Last question today. This is a 56-year-old woman with acute painful sensory and motor symptoms over 6 days in all 4 extremities, but not in a length dependent. In fact, the way it starts is that she has a problem in the right hand in what would be considered the median nerve distribution, followed by the left hand in the ulnar nerve distribution, followed by the right leg in this peroneal, we now call the fibular nerve distribution, followed then by a sural nerve distribution in the left foot. So something that's sort of progressing in single nerve distributions. You make you give a thought to the cause for this, and what should your workup look at? What presents in this way most concerningly, I guess. Monoclonal protein neuropathy, B12 deficiency, diabetes, drug-induced neuropathy, or a vasculitic neuropathy. All right, so this is a much harder question. As you can see, E was the most common answer, and that is the correct answer, vasculitis. But let's talk about this briefly. So monoclonal protein neuropathies, like a MEG protein or something to do with um, a cancer, would usually be a length-dependent symmetric neuropathy. B12 deficiency, length-dependent symmetric. Diabetes, usually length-dependent, but it also gives rise more to compression neuropathies, but it wouldn't happen, all these compressions wouldn't happen over 4 days. It might happen over 4 years or something, but not 4 days. Drug-induced are typically symmetric. It's vasculitic neuropathy, and what's happening here is that it's a blood vessel problem, and the vessel to the nerve is injured, and so the nerve essentially has a stroke, ischemia. And so that is how you get sort of single nerve distributions. We refer to this as mononeuropathy multiplex. And if it's vasculitis, you could refer to as mononeuritis multiplex rather than neuropathy. So the itis means inflammation. But thinking about vasculitis, the ANA, ANCA-positive vasculitides, whether with eosinophils or not, rheumatoid factor, cryoglobulins, that sort of thing is where you'd be headed with a vasculitic neuropathy. 155, I think. Ananth, I don't know if I have time for some questions, I guess, or happy to take them.
You do. We have a couple minutes. Thank you, Dr. Krause. Well, thank you so much. We, as always, really appreciate you leading this lecture and participating in the course.
Yeah, my pleasure. Thank you. Have a good day, everyone. Good luck with your test.